Welcome to our session of Paelon Health Education Series. My name is Lucia Okogu. I am a medical doctor here at Paelon Memorial Hospital. Just a little bit about Paelon Memorial Hospital. So we are a boutique hospital. We have 5 branches, 2 in VI. One is a day clinic, our newest branch, which is at 175A Moshood Olubani Street off Ligali. We have a hospital also in VI, situated on Amadou Bello. We have also a clinic in a hospital in Ikeja, one in VGC, which is a clinic, and also our branch in Delta State. Okay, so we are a guideline and protocol-driven hospital, and as a result, provide evidence-based, patient-centered primary, secondary, and also tertiary healthcare. We believe in integrity and are often sought out for our honest professional second opinions. Whilst trying to be a one-stop shop, we are careful not to overstep our bounds. We owe a lot of our success to our supportive and responsive colleagues in other disciplines. With an excellent track record, we have earned the first Safe Care Level 5 award in Africa, and we try our best always to maintain that. We have good quality care and quality improvement. We did it again in 2020, and we are still the only hospital in Nigeria to have earned the Safe Care Level 5 award. Today, we will be talking about fever beyond malaria. And this is something I think that is quite important because we run into patients that tell us that they felt ill or they felt that they had fever and they self-medicated with malaria. And today we will learn that not every fever is malaria. Our guest speaker today is our one and only Dr. Ngozi Onya. She is the founder and the managing director of Paelon Memorial Hospital. And what I have to say about her definitely does not define everything about her. So Dr. Ngozi Onya is a 1982 medical graduate of University of Ibadan. In 1998, she obtained her fellowship of the West African College of Physicians in pediatrics. Her research was on pediatric HIV infection. She is a certified travel health physician. She had 28 years of medical practice in both public and public health sectors and private sectors as well. Her most notable role being her 10-year stint as the company medical advisor in Nigerian breweries, in which capacity she oversaw the award-winning and globally acclaimed Heineken HIV/AIDS workplace program. In 2010, she established her own practice, Paelon Memorial Hospital, founded on the principle of providing quality healthcare in one place. In keeping with her interest in infectious diseases at the outbreak of the COVID-19 global pandemic in 2020, she led her team in the forefront of the private sector response by repurposing our Ikeja branch as the foremost private COVID-19 treatment center. Today, we have the privilege and opportunity to hear more from Dr. Onya on fever beyond malaria. So I will hand over to her now without further ado. Dr. Onya.
Good evening, everybody, and thank you, Ifama, for that grand introduction. Thank you, everybody who's joined this program to listen to me on the topic fever beyond malaria. So this is the outline my presentation will follow. I will introduce, I'm not sure that's very necessary anymore, Ifama had done a good job of the introduction. And I'll set out the objective for this presentation, what actually motivated me to make this presentation. I will talk about fever as an entity, the causes of fever in general, and then I will show a study that was conducted in Nigeria in 2014 on the causes of fever in Nigeria. I will talk about arboviruses, and then I will talk about malaria or dengue fever, and then some matters arising from my presentation. I'm aware of the fact that I have a mixed grill of people on this webinar. I have the eggheads, but I also have laymen. So for the eggheads, please don't feel insulted by how basic my presentation will be. My presentation is actually targeted mostly at the it's mostly targeted at the audience, the people who have a fever. But also, when I set out my objectives, you will also see my second objective for the presentation, which now targets the eggheads. And then for the laymen, as I will call them, don't be upset if some of my terms are a bit technical. I will try as much as possible to speak the language everybody will understand. So I think Ifeoma did a good job of this already. And so I'll just go straight to my objective for this presentation. And I'm sure somebody on this call will recognize that bowl of yam and eggs. So, and I'll tell you about yam and eggs. So my first objective is to create awareness in the general public. So I can see some people who are not medical people who are on this call. But also amongst clinicians who see patients. Okay. But also another very important objective is to generate interest among the eggheads, our researchers and academicians. I'm a proud yam head, so I'm just a plain clinician. But then I'm in good company with certain doctors, particularly a doctor who was just a country physician, a country doctor, who observed many years ago that milkmaids who contracted cowpox did not get smallpox. That was the single most important thing that led to, or that was the observation that led to the single most important public health intervention in the last 2 centuries, vaccinations. So there's nothing wrong with being a simple clinician. We are there to see the patients, and then it's up to the academicians to do the research. So let me start by defining fever, very, very basic. It's a temporary increase in the body temperature when it goes above 37 degrees. So up to 37 degrees is fine. It's noteworthy that it is temporary and usually will return to normal. And it is a sign that something out of the ordinary is going on in the body, and it's usually not a main cause of concern in adults. However, in children, even a small increase may indicate a serious infection. So it's taken often more seriously in children than in adults. We must also know that fever is not something that is negative, because it plays a key role in fighting infections. So how do we determine if a person has a fever? Usually you can take temperatures. You can either use an oral thermometer or a rectal thermometer or a tympanic thermometer in the ear, on the forehead, a temporal artery thermometer. Okay. However, the oral and the rectal are the most accurate. And for children, we actually recommend the rectal. Difficult, but it's usually the most accurate, and not so difficult if it's the mother doing it. Okay. So when do you have a fever that will make you think you need to see your doctor? For children younger than 3 months, when the temperature goes above 38, it might be time for you to visit a doctor. For children between 3 and 6 months, when the temperature is getting close to 39 degrees, and then, or if the child is, in addition to the fever, even if it's only 32, 37.2, but the child seems irritable, lethargic, uncomfortable, then you might need to see a doctor. For older children, aged between 6 to 24 months, it's also the same, 38.9. But if it lasts longer than 1 day, if it lasts longer than 1 day, then you should see a doctor. If, however, there are other symptoms such as cold, cough, diarrhea, you might want to see a doctor sooner. These are just guidelines, they're not cast in stone, but just to give an idea. Okay. For children above 2 years, if a child is responsive and active, then there's no cause for alarm. If, however, the child is listless or irritable, vomiting repeatedly, has headaches or tummy ache, then it might be time for you to see your doctor. Also, any fever that lasts longer than 3 days, please see a doctor. For an adult, we are more tolerant of fever. So a temperature greater than 39.4 degrees, it's time to see a doctor. Or even a lower temperature associated with severe headaches, a rapidly worsening rash, which might be suggestive of meningococcal meningitis, sensitivity to bright light, a stiff neck or pain when you bend your neck, if there's mental confusion, persistent vomiting, difficulty with breathing or chest pain, abdominal pain, pain when urinating, or convulsions. Definitely, nobody needs to tell you that you need to see a doctor, even if the temperature is only 37.2. Okay, and what are the common causes of fever? Usually fevers are caused mostly by infections, viral infections, bacterial infections, and other organisms, such in the protozoa, such as protozoa or fungi. Because the truth is, I'm speaking from Nigeria, and the commonest cause of fever in Nigeria is malaria, caused by Plasmodium, which is a protozoa. Of course, fungal infections can also cause fevers, particularly in immunocompromised individuals or individuals in like intensive care who have been on antibiotics for very long. Common infections that we recognize in Nigeria, number one, COVID virus. We all know COVID very well now. It's not the commonest, but it's the one we all fear the most. So, but so many other viruses, other coronaviruses, all kinds of other viruses we call respiratory tract infections. Then, of course, bacterial infections. And then other things will be things like autoimmune illnesses, malignancies can give fever, drug reactions, and sometimes even following an immunization. And then finally, there's the fever of unknown origin. So you have the person has the fever, you look through and through, and then you cannot find the cause for the fever. It's referred to in medicine as fevers of unknown origin. So this article was published in 2014, and the authors were VNV Enya et al. And it was about etiology of fever among under 5 in Nigeria. And they studied 202 patients, Massey Street Children's Hospital. Massey Street Children's Hospital is our foremost children's hospital located in the center of Lagos, probably the busiest children's hospital in Nigeria. And they saw 202 patients and they studied them. And the diagnosis that were made for 186 of those children, 92.1% of the children, a presumptive diagnosis of malaria was made. And this speaks to the fact, to what Dr. Kogu said about not every fever is malaria, but the first thing anybody thinks of in Nigeria when you get a fever is malaria. So 186 children were presumptively diagnosed as malaria. However, when laboratory tests were done, and there's no reason why we do not do a laboratory test now, we have extremely reliable, rapid diagnostic tests, what they call the lateral flow tests, that are very, very reliable, very easy to use. And when they did the tests, only 47 of those 186 truly had malaria. 16 were diagnosed as having acute respiratory infections. In reality, 31 had acute respiratory infections. HIV was the cause of fever in 10 of the children. So that comes to a total of about 88 patients. So my question is, what was the cause of fever in the other 118 people that we couldn't find a cause for fever? I will go back to my previous slide. Please note that presumptive diagnosis of malaria was 92%, but in reality, only 23% had malaria. And so this presentation is about that 118 people that did not have malaria and did not have HIV and did not have upper respiratory tract infection. Beyond malaria, what else? So let me talk about arboviruses. I'm sure for all of us who live in Nigeria, this is not an unfamiliar mosquito. It's different from the anopheline mosquito that transmits malaria. This is a mosquito that flies in the daytime, the black and white mosquito, very peculiar, we all recognize it. Okay, this mosquito. It's different. It's called the Aedes. It's a species Aedes, and there are many, the genus Aedes, and there are many species. So there are Aedes aegypti, etc., etc. I'm not going to be very technical on that. But it's not the Anopheline mosquito, it is the Aedes mosquito. Okay. We know it is native to both temperate and tropical habitats. Nigeria is a tropical habitat. Then the description, typically the narrow black body with light and dark scales on their abdomen. Their females will deposit their black-colored eggs on moist surfaces such as mud, close to water lines, but also in plastic containers and tires lying around the home collecting stagnant water. They feed during the day, unlike the Anopheline mosquito that fly at night. So their peak activity is at dawn and at dusk. Okay? They prefer to feed and breed outdoors, but we also see them in our homes sometimes. But there are those mosquitoes that bite you in the daytime when you're sitting outside your house. Okay. And then I want to talk about two illnesses. I want to talk about malaria and dengue fever. No, sorry, maybe that I'm jumping ahead of myself. So let me talk about arboviruses. Arboviruses are viruses that are transmitted by the Aedes mosquito. Viruses transmitted by the Aedes mosquito are described as arboviruses. And there are many of them. The one we all know about is yellow fever. So yellow fever is an arbovirus. It's an arbovirus, yes, transmitted by mosquitoes, okay? By arthropods, really. Mosquitoes are arthropods. So that's where the word arboviruses come from. So yellow fever is one, for example. Another will be chikungunya, that is ill-recognized, and a couple others. But dengue fever is the one that concerns me today. It's one of the arboviruses, okay? And so when I think about dengue fever, transmitted by this mosquito that we know is very prevalent in Nigeria, and look at the symptoms of malaria and the symptoms of dengue fever. So malaria causes a fever, so does dengue fever. Malaria causes abdominal pain, so does dengue fever. Causes chills, so does dengue fever. General feeling of discomfort and being irritable, the same thing. Headaches, nausea and vomiting, diarrhea, pain behind the eyes, muscle or joint pain, fatigue, rapid breathing, and then of course they will both cause rapid heartbeat, because any fever will cause rapid heartbeat. Then it starts to differ a little. So dengue will cause swollen lymph nodes. Dengue will cause a rash. Dengue will sometimes cause bleeding from the gums and the urine, or bleeding under the skin. Malaria doesn't cause this. Notice it at the bottom, okay, of the list. Dengue fever is caused by a single strand RNA that belongs to the family of flaviviruses. That's the same family as yellow fever. There are 4 different serotypes of dengue fever. At least is the commonest arboviral infection globally, and you have 50 million to 100 million cases per annum globally, and of which only 500,000 will present with the hemorrhagic disease. We have always considered and classified dengue fever as a hemorrhagic viral fever, like yellow fever. But of all patients who get the infection, only 0.5 or 1% of them will present with hemorrhagic infection. The world's most recent largest epidemic was in Cuba in 1981, where they were reporting up to 11,000 cases every day. But even during that epidemic, for every case that was recognized and diagnosed, about 14 cases went undiagnosed. Okay. So I have a couple of questions. So this is really what I really wanted to present to the House. Should we really continue to think of dengue fever as a viral hemorrhagic fever? Because I think the reason why we don't diagnose dengue fever is because the people are not bleeding. So if they're not bleeding, it can't be dengue. Dengue is a viral hemorrhagic fever. But is it simply one of those non-malarial fevers? I don't know. I'm sure there are a couple of doctors on this group. Has any doctor practicing in Nigeria on this group diagnosed dengue fever ever? Do we really think that with so many people getting infected globally and with the prevalence of the Aedes mosquito in Nigeria, do we really think dengue doesn't occur in Nigeria? Are we not looking for dengue? Is it time for us to start looking for dengue? So, because of my interest, so I made a presentation to the South African Society of Travel Medicine sometime last year on arboviruses, and I think that's where my interest was really piqued. So I bought a rapid diagnostic test, one of those lateral flow tests for arboviruses, for dengue. I don't know who the manufacturer is. I can't tell you how reliable it is, and I'm not going to make any claims based on this. But my own interest, remember, I'm built in the mold of Dr. Jenna. I like to observe. For my own interest, I said to my lab scientist just about 2 or 3 weeks ago, I said, because I was planning to have this webinar, I said, for everybody who is sent to the lab for a malaria test that tests negative, so it's not malaria, can you please run this dengue test? And at my cost, at my expense, it's fine. Okay, just to add to the body of knowledge. So these are the patients we saw. Of these 20 patients, the first 20 in the pack, we will open another pack. The first 20 in the pack, we had 2 patients who tested positive for dengue, who had fever. One tested both positive for both IgM, which is a recent infection, and IgG, which is not a recent infection, which is an old infection, the memory. And another tested positive only for the IgG. All the others tested negative. So 2 over 20, even if dengue wasn't the cause of fever in the second patient, but it could be, because we know that the IgM, so this presentation is not about dengue, it's just about fever beyond malaria. Maybe after this, we will do a proper presentation on dengue. This is just to be of interest. We know that the IgM, which is the early antibodies, disappears quite quickly within 5 to 7 days in a patient. So even the second patient who was only IgG positive, could he have turned already IgM negative? Because we know Nigeria, that our health-seeking behavior is not quite ideal, and people tend to present rather late in hospital. May that be the reason why. So 2 out of 20 just randomly tested positive. It's interesting also, this is just that 2 also out of this 20 had elevated white blood counts. We often recognize bacterial infections. Are we missing something? That's my question. Thank you for listening to me. I must recognize the presence of someone who I'm so glad joined this webinar, in the person of Dr. Ifedayo Adetifa, the Director General of the NCDC, because I regularly would blow up his phone, asking him all kinds of questions about what are we looking out for? What are we screening for? Do we have any surveillance on dengue? Do we have any surveillance on this or that? And I'm glad he's graced us with his presence on this webinar. Thank you, Dr. Adetifa, and thank you for everybody else who's on. Thank you. If I'm over to you.
Thank you, Dr. Onya. That was a wonderful presentation, just packed full with information. Just to summarize, so Dr. Onya took us through the definition of fever and the different age groups, and basically, yes, it's not cast in stone, but how we would define fever in the different age groups, the different causes of fever, and then we went through the study that was done at Massey Street Children's Hospital. It was quite interesting for me to learn about the Aedes mosquito, I always wondered whether mosquitoes were different in that they would start biting during the day. And it was interesting to note that it was the Aedes mosquito that actually feed during the daytime. And it's not our family members or any witch or wizard that is coming in the form of mosquitoes. We also went through the difference between malaria and dengue, and the study that was done, or the ongoing study that is being done here at Paelon Memorial Hospital. At this point, I would ask that if anybody has any questions or comments, that they raise their hands and we'll take the questions. And also, if you don't want to ask, you can drop it in the chat. I think we already have one question in the chat if we don't have any hands raised. So, oh, okay. Ebu, please kindly unmute yourself. Ebu, you can unmute yourself, please.
Yes. So thank you very much, Paelon and Director, Dr. Onya, for the presentation. I say it's quite educative. Truly, we tend to believe that every fever is malaria, particularly in children. And I think the era of trying to do a rapid test diagnosis is becoming at least more rampant in Nigeria. Unfortunately, I would say so many other people, centers are still given drugs for every fever without, looking for the possible cause. I want to say that I think it's good that we are raising our awareness about dengue as a cause of fever, particularly for people who are not immune. Because if you see the transmission pattern that Dr. Onya discussed, is that it's, around the house, in the leftover tires and plastics. So usually it tends to go among the low socioeconomic group. And unfortunately, these are the people that will end up doing self-medication. And I want to say that for now, I'm not sure there's much treatment for dengue. I know prevention is the main thing to do, particularly for those who are coming from outside the country or going to an endemic area. And lastly, to say also that the fact that it doesn't have in many cases, it may even be asymptomatic. In other words, you can be infected and yet not even show symptoms. And the few that showed symptoms, because we have named it hemorrhagic, that attempts to bring us to the point to say it is possible yellow fever or dengue. Unfortunately, the bleeding doesn't come often. So I'm just saying that I think it's a good beginning, and thank you because you are already doing something small in your center. At least we raise awareness, and many of us will also try to see we can get the kits. How many of our children actually have this dengue and they are diagnosed wrongly? Because when people try anti-malaria, even after a RDT, they still go on to give anti-malaria sometimes. But not all fever is malaria. Thank you for that.
Thank you.
Thank you to one of my eggheads on the group. By the way, I'm the yam, the egg. Yam and egg, a fantastic combination. Who just work with a professor at the Obafemi Awolowo University Teaching Hospital.
Okay. Thank you, Professor Ebu. Please, can you lower your hand? So we have someone else, Mr. Joseph. Please kindly unmute yourself.
Okay. Thank you very much for this wonderful presentation. Well, I have a contribution that truly, not all fever is caused by malaria. And even at times, there are occasions where you see a patient who has a fever, who turns out to be malaria positive. It is important to note that it's also still possible for that patient to have another infection. The point I'm trying to make is that not all patients with a positive malaria test ends up coming up, having malaria as a final diagnosis. So I would encourage all clinicians to have a broader mindset when seeing patients, that everything doesn't boil down to malaria. Even when they come up with a positive malaria test, there could still be other possibilities. Thank you very much.
I think the point Dr. Joseph had just made is that you can have co-infections. So malaria can coexist with another infection. Yes, we recognize that. I see a question here. I don't know if the person will ask, but let me speak to it because that's something I'm very passionate about. And that's about the reliability of rapid diagnostic tests. They are actually now the standard of care recommended by WHO. In my experience, I find a microscopy less reliable than rapid diagnostic tests because that's too operator dependent. So it will depend on the skill of the operator. It will depend on the integrity of the operator. It will depend on the equipment, the microscope. How good the microscope is. If you have a microscope but already the lenses are blurry, how do you see? The RDT is idiot-proof, in my opinion. You see, this same kind of study I did here, I did when I was the medical advisor of Nigerian Breweries. I did 100 tests with RDT and then 100 with QBC in ELISA, where we had a well-trained lab scientist who had gone to the malaria center in Louth to be trained in how to identify the parasite, so I could rely on her. And of the 100 tests I did, so I did 100 RDT malaria, 100 QBCs, and 100% of the time they were the same. When it was negative on QBC, it was negative on RDT. When it was positive on QBC, it was positive on RDT. Since then, I stopped using, and I'm talking about maybe 2001 or 2. Since then, I don't use QBC. My standard of care, and I'm happy WHO is also on board, is the rapid diagnostic tests. They are very reliable. On the other hand, I have had lab scientists that will tell you malaria, we all know that. You know, plus, 2 pluses, trace. I will tell you a story. When I was medical advisor of Nigerian Breweries, and this is very important for the RDTs, I had an expert who was director of finance at the time, who said to me, God, I think I have malaria. I took his blood sample, sent it to the lab. It was positive. Then we didn't have an in-house lab. In fact, indeed, this story is what led us to having a well-resourced in-house lab in Nigerian Breweries that still exists today. One of the best resourced labs in Lagos today. So the sample went to the lab and came back positive. So I treated him with this, I've forgotten what it's called now, the atobacone combination, Malaria, was a brand new drug. I had just come in from a conference in Amsterdam and it was new in the market. I knew there was no resistance to malaria, and I gave it to the patient and he improved. And then, trying to be an overzealous doctor that I sometimes am, I took another sample after a couple of days and sent back to the lab. He was feeling perfectly well. He was back at work, sent back to the same lab, and he still came back as trace. So I was confused. I really believed it. So I went to the lab and I said to the scientists, may I have a look at the slide? I want to look at the slide that showed that he still has a trace of malaria parasite in his blood. And he said to me, will I be able to identify the parasite if I saw it? I said I wouldn't be here if I couldn't identify the parasite. I'm sure you all know that as pediatricians, we always have a side lab. So we learned to identify things as well. So he said to me, he had discarded the sample. This was only the question of maybe 2 hours. He had already discarded the sample. I said, not a problem. I'll go back to the brewery and I'll take blood from the patient again. And I did. And I brought the blood back to the lab. I honestly did not think there was anything fishy. I was just trying to be efficient or whatever. And so I sat down for 2 hours waiting for this man to find the parasite. And then he finally confessed that he didn't look the first time. That since on the request form, I said query malaria, so he decided to say plus. And I'm sure we all know that this happens very often. So for that reason, I will recommend the RDT over the microscopy. However, we do know that the gold standard is still the RDT when it is well done by the right person in the right place. Thank you. Please go on. From over to you.
Thank you, Dr. Onya. So we do have a couple of questions on the chat, and we also have Ibrahim Salau, who raised his hand. I'll just take some of the questions from the chat and go back to Mr. Ibrahim. So from Victor Ante, he asked, what laboratory investigations diagnosed acute upper respiratory, since there was a difference between the presumptive diagnosis and laboratory diagnosis? I think he's referring to the study done at Massey Street Children's Hospital.
Just take all the questions, I'll answer them one after the other.
Okay, okay. And then the next question you had answered about the RDT. And then after that, there's a question about, okay. Thank you from Olurinu Jose. Thank you, Doctor, and the team for the insightful presentation. I believe we all have experienced being bitten by black mosquito, and given that not all fevers are not malaria, when can we ask a doctor to check for dengue, since it is not a disease that is usually suspected? The next question after that, is there any particular RDT test kit you would recommend? And then from Olashende Eletu, great presentation. How common is typhoid fever? Okay. So Henrietta Okafor is asking if the...
Let me take those so I don't forget. So the first question about, thank you for your questions, which shows you're interested. I mean, you're following interested. The first question, which is the question about what investigation for the upper respiratory tract infection, I really cannot say because that was a study that was done at Massey School. However, from the little one we did, I guess if I type the somebody please mute. Somebody please mute. Okay, yeah, thank you. So I was saying that if I get from my own, the little thing, if we can call it a study we just did in our lab now, I guess for those who had leukocytosis, and if they had respiratory tract infection, we could say they had upper respiratory tract infection, but I really don't know because I'm just reporting someone else's study. That's for that question. The second question was about, well, the one I remember the second one. Yeah, Renu's question. Yeah, that's a very good question, Renu, but it's one of the things that I hope to achieve by creating this awareness. And it's one of the reasons why I have the Director General of the NCDC on this call. They are the policymakers. So I'm not even sure it's really it's in the place of a patient to ask for a dengue test, because even if you did, the truth is the test kits may not be available. The test kits may not be available. So it's a policy thing, and that's why I'm raising the awareness. And the fact that you've asked this question now gives me that impression. Somebody asked about what kit will I recommend? No, I don't know any. I don't know which one, but I just said to my lab scientist, look around and see if you can find dengue kits. And she did. She might be, if she's on this call, she might be able to tell us the name. So I'm not here to promote any product because I don't know which is reliable. And when I said to the DG of the NCDC that I had a test kit, he said I should send it over to them. Maybe they can validate it. So maybe I will do that. And maybe the next time we discuss dengue, we might be talking about valid kits or somebody else on or validated kits. Maybe somebody else on this call might already know some, but I don't know any. And then talking about typhoid fever, to be honest, Dr. Letra, I'm sure you're asking this question to be provocative, not because you really want an answer, because I'm sure like me, you know that typhoid fever is not common at all. That is an overdiagnosed condition in Nigeria, just like malaria, for the same reason. Because of the test that is used, the outdated and fairly useless Vidal's test that is used. So if I remember from medical school, we were told that to make a diagnosis of typhoid fever using the Vidal's test, you had to have a four-fold increase in the titers over 2 weeks. If you waited 2 weeks for a patient with typhoid, they'll be dead. So you can see that by definition, it's not a useful test. You have to see, so I do it today, it's 1 in 20. And then I do it in 2 weeks' time, and it's 1 in 160. Then I can say a patient has typhoid. If I had to wait that long, the patient will not be alive. So the vitals test is a totally irrelevant test. It's not useful. But I think it just, over time, it has become a habit. Just as it's a habit to say everybody who has a fever has malaria, in the same way it has become a habit to say everybody who feels a bit unwell, often stress, has nothing to do with even fever, will be typhoid. So I have a headache and I feel a bit unwell. It's typhoid malaria. Meanwhile, malaria is called a fever. Typhoid is also called a fever. So with no fever, just that I feel a bit unwell and I have a headache, it's typhoid. So I think the answer to this is that it's not common, at least in my experience. In 40 years now of practicing medicine, maybe I've seen maybe 4 or 5 cases I can say were truly typhoid fever in 40 years of practice. But then I also acknowledge that I practice in the highbrow part of Lagos, where typhoid will not be very common at all, because typhoid is often an illness that is associated with poor sanitation. Thank you. And I don't know, Saying, did you want to add to my comment? I think you should, because I'm sure you asked your comment, your question for a reason.
Okay. Can you hear me?
No,
Yes,
well,
we can hear you.
enough. Yes, we can hear you now.
Oh, he's off.
I think, yeah, but I'm sure he will join again. And when he joins again, he will answer.
Okay. Okay, so until he comes back, we can take from Mr. Ibrahim Salao. Please kindly unmute yourself. Thank you.
Hello, everyone. Dr. Onya, good evening, ma'am. Can you hear me, Dr. Lucia?
Yes, we can hear you loud and clear.
Okay, thank you. Please, I had this experience while growing up in the countryside. So it has to do with temperature and children. So there was this experience, maybe quite not 1 or 2. You see some children having temperature. And the next thing that happened is convulsion. And because of this, whenever my children are having temperature, so I used to have this fear that if it's not immediately taken care of, it will lead to convulsion. Please, doctor, you didn't mention, is there any relationship between the high temperature in children and convulsion?
Definitely, fever is a common cause of, probably the commonest cause of convulsion in children is fever. So febrile convulsion, very well recognized. So it's a symptom of the fever. Some children will convulse just because their temperatures rise. Somehow it affects the brain and they convulse. So yes, febrile convulsion, very well recognized. And the commonest cause of convulsion in children is a raised body temperature. So yes, it's true. Which is why if you notice for children, the threshold for fever is much lower. I said for adults up to 39.4. But for children, particularly for younger children, the younger the child, the lower the threshold for fever for you to seek care. You noticed that, Mr. Salawu, did you?
Yes, ma'am. Yes, ma'am. Yes, doctor.
Yeah.
Thank you.
Thank you. I saw Dr. Blessing. Sorry, sir. Can you unmute yourself? Is he back in? I think he's still on this call. Okay. While he gets back on, there's a question on the chat from Henrietta Okafo. It's not really clear, but she says, is the experience same in children? Henrietta Okafo, please, if you are on the call, can you please clarify your question? Henrietta?
Yes, I'm here. Good evening, everyone. Thank you very much, Dr. Ngozi. I just wanted to know if your experience with regards to the RDTs is similar in children, because I found that children, they may test negative. I want to, adduce that to the fact that their parasite density counts may not be as high as you have. in adults. They may test negative, but when you do the malaria parasites smears, you find that it's positive. So the issue here is the reliability of the MRDT.
Dr. I think you're Dr. Kato. Do you do those tests? Did you hear the story I told?
Did I?
Hear my story about the lab tests?
Yes.
Do you do those tests yourself and identify the parasites?
Identifying the parasites?
Yourself.
I don't, but what happens?
You see, the
issue is that when they are giving anti-malarials, they respond. You don't give any other treatment, they respond.
But you know what, Dr. Kato? Dengue fever is a viral infection. And as you and I know, viral infections are self-resolving. So even if you didn't give that child the anti-malarial, the child will have gotten better with the viral infection. It's only 0.5% of people who will want to have a severe hemorrhagic illness. Most people will recover without any treatment. So you see, the comment you've made now validates my point that everything that is the presumptive diagnosis of malaria still seems to be the standard in Nigeria, when the WHO has said for many years that we should not make presumptive diagnosis, and we should always be guided by a lab test.
I totally agree with you.
I'm a pediatrician. I have never, since 2002, treated any child for malaria if I had a negative test. I'm also happy to say all the children I've treated have survived.
You know, I don't know, because I have conducted, studies in the field where we screened with rapid diagnostic tests. But those children, because the threshold for inclusion into the studies wasn't up to what we used as our inclusion criterion, we didn't include them. But those children had malaria parasites, and these were,
Well, we're still saying the same thing. Unless Dr. Kapo, you can tell me that you were doing those smears yourself, then I will say.
Oh, sure, I participated.
No, you did every smear yourself, and you saw parasites, and you had a negative RDT. It's possible, I cannot contest because I wasn't with you.
Yes.
But my opinion is, every time I have seen a negative RDT, I've never given antimalarial, and my patient have recovered. What I give, on the contrary, is my phone number to the mothers, because they need that assurance. If she doesn't get better, let me know. If she doesn't, because I know if I didn't give my number, which is why I don't sleep, but if I didn't give my number, they will go and buy the antimalarial themselves. So I tell you, trust me, if the child doesn't get better, let me know. And in the end, they will send a message, oh, the child is better now. And now they're all firm believers. Now they will, if most of my patients, if you offer them antimalarials, no matter how ill their child is, if the test is negative, they will tell you they will wait. But I like to read something that Iria Osai Bobo wrote. I don't know if everybody has read it, but this cheers my heart. It says, thanks for this timely presentation. NCDC, in conjunction with partners, is conducting a pilot surveillance project for acute febrile illness in 6 sentinel sites, public hospitals. We hope this reveals the true burden of fever beyond malaria. And I clap to that. Thank you very much.
It's timely too. Thank you very much.
Somebody also asked the same question about clinical malaria. Lab tests came out negative, but patients responded to treatment. I just made the point that beyond malaria, when I'm still getting comments like this, it's as if I didn't communicate properly. Beyond malaria, the common cause of infection of fever will be viral infections. Viral infections are self-limited, so self-limiting. So if I have a viral infection and I take paracetamol, I will get better. If I take antibiotic, I will get better. If I take chloroquine, I will get better. If I take chalk, I will get better, because the illness will have gone by itself anyway within 5 to 7 days. So if I have a febrile illness and I take an antimalarial, I will attribute my improvement to the drug, but really the truth is I will have improved anyway. And that's the point.
Thank you very much, Dr. Onya, for that and for all the questions that are coming in. We do have Ifedayo Adetifa, who has raised hand. Please kindly unmute yourself.
And that is our Director General of the NCDC. So please let's take his word very seriously.
Well, I just, good evening, everybody. I'm not going to ask a question, but I thought it was important that I, again, convey my appreciation for the initiative taken by Paelon under the, of course, the leadership of the indefatigable Dr. Onya to have this event. I think it's important because, yes, fevers are a public health concern and associated frequently with misdiagnosis, and again, in the season or context of the challenge we have with antimicrobial resistance, the wrong diagnosis of fever is also a significant contributor to misuse of antibiotics, misuse of anti-malarials, and other medication, which we know all contributes over a long period of time to reducing the efficacy or the development of resistance to these drugs. I think the second important thing to highlight from this meeting is that we do need now to increasingly investigate fevers properly. A lot of us have all grown up, both from personal experience and even from our early medical training, to depend significantly on presumptive diagnosis, and the challenges of infrastructure, equipment, and all of that also in many of our teaching hospitals that serve as training, provide training to generations of doctors, means that we have physicians that are no longer sort of familiar with the range of diagnostic tests that should really be done to get a diagnosis of fever before we treat. And we need to do this now. And I think people often talk about the absence of resources, but I think the biggest challenge now is actually people not demanding for equipment, for tests, and all of that, so that those who are in control of resources can actually invest in there and realize the number of the amount of savings that you make in terms of costs of unnecessary hospitalization, unnecessary medication, when you have a proper diagnosis. So hopefully a lot of this will continue. We'll get more converts, and as the NCDC and others continue to work in the space for febrile illness surveillance to try and generate more information, we will hopefully get to a point where we can change the guidelines and hopefully improve practice, but for not just for children who our constituency as the pediatricians that we are, but for everybody else in the country. So thank you very much, Dr. Onya, for this very useful presentation and for the initiative taken in your hospital to show us more about fever beyond malaria. Thank you very much.
Thank you very much, Dr. Adetifa, for finding time in your busy schedule to join us. One of the eggheads too.
Thank you, Dr. Onya. Thank you for that. So we have another question on the chat, and I believe that Dr. Letu is back online. So while we wait for him to unmute himself, I'll take the question on the chat. The question is, how long does the rapid test stay positive after malaria?
Thank you. That's a very good question, because it raises the issue of false positive malaria tests, which actually is more of a reality than false negative. Because yes, the test can stay positive sometimes for as long as 10 days when the patient is fully recovered. So at this point, you need to be guided by the patient's symptoms. So if the patient feels well, even if the rapid test stays positive, actually, what I'd rather say, there's no need to do a rapid test, to repeat a rapid test. except the patient doesn't improve. So there's really no need to do a rapid test after treatment, if the patient improves. It's only if the patient doesn't improve that the rapid test will be relevant, because yes, sometimes it can stay positive even when the patient is better and well, and it's a false positive. And that actually is much commoner than a false negative. Thank you for raising that very important issue.
Thank you, Dr. Onya, for that.
Hello.
Okay. Oh, wonderful.
Yes,
okay, you're back on. Over
good
to you.
afternoon. Sorry, I had internet challenges. Thank you very much, Ngozi, for this presentation. Okay, like I said, just similar to your own experience, in my over 30-something years, I've only seen 2 confirmed cases of typhoid fever. And I see quite a lot of people come to me and say, oh, I have malaria and typhoid. And each time I hear that, I get very upset, because all they've simply done is somebody has done a without test, just like you mentioned. And they say, oh, the titer is 1 in 160, and once is greater than 1 in 180, then it's typhoid fever. So I'm beginning to wonder why we as physicians would not properly evaluate our patients before we give them a diagnosis and then start treating them. So I'm happy you've highlighted this. Quite a lot of the fevers we see are viral, and even if we do nothing, the patient will get better. So thank you very much, Ngozi, for raising this.
Okay, Dr. Iletu, I would just like to ask your opinion on this. So we do have patients that come that pressurize, in quotations, the doctor to give a diagnosis. So they will come and they will say, I'm not feeling well, I have malaria, or I think I have malaria, and this is how I feel when I have malaria. And you have probably a medical officer that is on duty that day. What advice would you give them? What do you think about that scenario? Has he gone off? Oh, he has gone off. Okay, Dr. Onya. Okay. Is he back? Dr. Onya, would you like to take that?
Yes, I've readmitted him, but while waiting, I think you just need to be confident, which is what the point I made about what you call safety netting. If you don't want to even use your personal number, you can give an email address, you can give your front desk number, or just give an appointment to come back. That often gives patients enough confidence. If you speak with confidence, so I will always, for example, turn my computer screen and let the patient see their results. I say, see, your malaria parasite is negative. Your full blood count, normal is between 4 and 11, yours is 5, that's normal. This is that, show them all that. I think you might just have, if there are symptoms, real symptoms, because most of the malaria typhoid, I'm sure you know, is stress, anxiety, depression, from the mental health origin, or from the mind, let me put it that way. So, but for those who have symptoms like fever, I think you have a viral acute respiratory tract infection. Wait patiently, it will go by itself within a few days. And if you don't feel better, reach me or come back in 2 days. You know, if you just give them that safety net to feel you haven't sent them home with nothing and leaving them vulnerable. And if they've expressed their fears to you, you think it might be meningitis, you show them why it is not meningitis. Most of them are happy to go. So you just need to invest the time, and you need to sound confident with facts, like you know what you're saying to them. And many of them will go confidently. I've never seen anybody, I mean, of course, I can be pressurizing to give them a treatment. You can also ask them to seek a second opinion. So rather than give a wrong diagnosis or do what I think know is wrong, then I give them the freedom to seek another opinion.
Thank you so much, Dr. Onya, for that. And I think that is something that we should all take home, especially to the medical officers that are on this call and those that are feeling pressurized by their patients that come in. Dr. Onya?
No, sorry, it's fine. I was going to tell Dr. Adetifa to shut down his camera. Okay. He's back on his desk. Okay, all right, okay.
Okay.
Right.
I heard another voice. Amina Bello, did you have a question? Okay.
No,
on the
sorry.
Did you have a question?
No, thank you. Sorry.
Okay, thank you. So on the chat, Dr. Kende Wanika Briggs states that in the monthly NHMIS report to the states, clinically diagnosed malaria is a medical suspicion of malaria where no malaria test is carried out. Where no malaria test is carried out for whatever reason, and not treating malaria with a negative test result. Okay, so she says, thank you for this.
Kenny, do you want to explain to us what you were trying to communicate if you are still on, Kenny?
Okay, thank you very much. Thank you for the presentation. Good afternoon, everyone. Yes, we submit monthly reports to the states, to local governments and states, and they usually have confirmed malaria, clinically diagnosed malaria, and clinically diagnosed malaria. Because we've been talking about treating malaria even though you're seeing a negative result. But what they refer to as clinically diagnosed malaria is malaria that the doctors suspect that it may be malaria, but for whatever reason, a test cannot be done. But the doctor will still go ahead and treat. It does happen at times, either the lab is not functioning or one thing or the other and you can't do the test, but you're still treating the patient. So it's not actually confirmed. The doctor has a medical suspicion, has no lab results, and will treat the patient anyway, rather than just treating a patient who comes with a negative result and you think it's still malaria and treat. So that's what I wanted to clarify.
Oh, thank you very much. Didn't know that was done. Thank you very much. Yes, we will share. There's a question about if we will share copy of this presentation. It is being recorded and we'll definitely share it. Then Dr. Elitu is asking you, Dr. Onya, if you have seen any case of Munchausen syndrome by proxy presenting as fever. This is actually a very interesting question. I know I have. Well, I haven't even pushed to see that. Dr. Onya or any other doctor?
Well, not fever as defined, so not with an elevated temperature, but fever as a symptom, of course. I have. So just a symptom of fever, yes. As a sign, no. In other words, I'm not able to, because they will say the child had a fever, the head is hot, they take the temperature on the 36 points. So I've seen that, yes.
Okay. Dr. Elotu, you asked this question, please, may I know why? Can you expand on that? Did you have any experience of this too? Are you back on the call?
Yeah, I am. Yes, I've seen a case actually as well. The mother saying that the child has fever, and then we've done all the investigations and we couldn't find anything. And the child wasn't given any medication, and the child got better.
I haven't seen a case. I've seen several cases.
Okay, it's interesting that for us to know that this also is a differential now for fever, symptom of fever. So people should please take notes. Munchausen syndrome. Okay, are there any other questions or comments?
I'll just make a final comment, and that is maybe it's time for us to start thinking about vaccinations against some of these illnesses. Although they're self-limiting because they cause so much trouble, so maybe prevention might be more important. And let's remember that the interventions we have in place for preventing mosquito bites, usually we think about them in the evenings. Dengue fever, the mosquitoes, Aedes mosquitoes bite in the daytime. Remember that.
Thank you, Dr. Onya. I must say that is my big takeaway points for today, that the mosquitoes that bite in the afternoon are the Aedes mosquito for dengue. So I think that is something that we have learned, and we should all take that away, as well as not every fever is malaria. With that, if we do not have any more questions or any comments, I'll just go through the chat again. Okay. We don't have any more. Thank you everyone for your time. Thank you for your active participation. Thank you, Dr. Onya. It was a brilliant presentation as usual. We look forward to many more presentations from you. To those who joined, thank you. Oh, actually, wait, there is a question. Was there a question? Okay. Okay, so they say, thank you so much for this presentation. This presentation has clarified why in one of the centers I have worked, malaria is not proven with an RDT. No matter level of fever, they must not be treated for malaria. Can the person please expand on what they're saying? Ethel? I'll be Ethel. Can you please clarify? Can you unmute yourself?
I think
Hello?
it's quite clear. Okay.
Hello.
Okay. Yeah. Okay. All right.
Hello, good afternoon, Dr. Onyan. Good afternoon. Can you hear me?
Yes, we can hear you.
Okay. What I'm trying to say, I've worked in a center where if you have fever, if a child has fever, no matter the level of fever, the child is never treated for malaria until it is proven with a rapid diagnostic test. The mothers will be so anxious. They will tell you all the symptoms they are seeing is symptoms of malaria. But if that kit does not say that child has malaria, the child is not treated. In fact, it is kept as a KPI for that unit. How many cases came in with fever? How many were proven to be malaria and treated for malaria? And how many was not proven and yet was treated for malaria? So it's a serious affair in that establishment. And I'm happy now that I'm hearing this presentation. But the take home here is that we never thought of dengue fever. That was just it. It's an eye opener now to know, now that I know the additional signs to look out for to suspect dengue fever. If they come into the community where I belong and I see something like that, I think I can make suggestions that, but the actual problem is the kits. It is not available.
The honest truth is that Ethel, it's almost impossible to differentiate dengue fever from malaria fever based on symptoms. They're almost exactly alike. So we will need to be able to diagnose dengue. That's the truth.
Yes.
Anything that is malaria could be dengue, and anything that is dengue could be malaria, except for the bleeding. That bleeding is very unusual. Yeah, it's very unusual.
Rash, you mentioned bleeding, yes. So
but those are unusual. So most dengue, 99.5% of people with dengue will not have bleeding.
Okay. Thank you so much for the presentation. I enjoyed it.
Okay. Thank you very much, Ethel. As we do not have any other questions, comments, or raised hands, I think we can close our webinar for today. Thank you again, everyone, for your active participation. Thank you, Dr. Onya. Thank you, everybody. With that, we will close out. Thank you. See you next time.